Hello friends, now in this lecture we're going to talk about the clinical management of third stage of labor. The key components that we're going to discuss are the physiology of third stage of labor. So we know that third stage is when the placental expulsion takes place, right? So it begins from the time since delivery of the baby till the complete placental expulsion takes place. We're going to talk about the components of active management of third stage of labor and the importance of each of those components in detail. We're going to discuss uterotonics in the third stage of labor, compare them, know the recent recommendations as well. We're going to talk about delayed cord clamping in detail. What are the benefits of delayed cord clamping? What are the recommendations regarding it, right? And then finally, yes, we will summarize in the end about the clinical management also. So to begin with, when we talk about the physiology, see here and you know already that the plane of placental separation passes through the middle layer, that is the decidua spongiosa. So remember here that this is the decidua basalis and it has differentiated into three layers, right? The deepest is the basal layer. Then you have a middle layer, that is the spongy layer. And we have the superficial one, that is the compact layer. Right? So as the plane of separation passes through the spongy layer, you can understand here that the compact layer is shed off, part of the decidua is shed off along with the placenta right here. Okay, that's why human placenta is a deciduate type of placenta, and the basal layer remains behind. Remember, from which the regeneration of endometrium later on in puerperium is going to take place. Now, the important point to note here is how does the placenta separate, right? What is the most important factor responsible for placental separation? And that is uterine contractions. Uterine contractions are as intense in the third stage of labor as they have been in the second stage of labor. Okay, and when the uterus contracts, remember, the fibers also shorten. So there is this decompression, as you can see, inside the uterine cavity, right, because of uterine contractions. And now imagine it as if, you have a big balloon, and you have a sticker attached onto the big balloon, okay? And the sticker is, let's say, the placenta and the balloon is the uterus, right? Now, when you're going to deflate the balloon, what happens? The sticker comes off, right? So what happens with the shrinking of the size of the uterus is there is this buckling of the placenta that takes place. Buckling of the placenta, meaning, let's say, it shears off from its attachment, right? Because the placenta is not contracting, it's the uterus that is contracting. So it shears off from its attachments and gets separated. In that process, bleeding also takes place behind the placenta, okay? Bleeding takes place from the sinuses here, all right? And understand here that it is these very same uterine contractions that are responsible for further expelling the placenta out, of course, helped by the maternal bearing down efforts also, right? And it is the same uterine contractions again, which are a method of prevention of blood loss during the time of delivery, isn't it? Right? So it is these very uterine contractions. Remember, the middle layer of the uterine myometrium, crisscross muscle fibers, the living ligatures, right? So as the uterus contracts, it is ultimately going to lead to hemostasis, right? Obviously, yes, this is the main mechanism of hemostasis. However, the body's coagulation system also contributes, okay? And remember here that if there is uterine atonicity for any reason, the placenta may not separate, may not get expelled, may remain retained, right? So understand this very, very important physiology. Now, next, let's talk about the methods of placental separation. There are two methods you're already aware of. The commoner method is the central methods or the Schultz method, right? In which it is the central portion of the placenta that separates first, right? Like we saw in the image previously, the center portion of the placenta separates first. And then when it comes out, you can see here that the fetal side, the shiny side, the fetal side comes out first or is visible at the introitus first. And behind, yes, there is this retroplacental hematoma. So yes, the visible bleeding is less with this central or Schultz method, okay? And if you look at the other method, right, which is the marginal method of placental separation, so placenta is attached here and it can start to separate from the margins also, okay? Now, as it separates from the margins, you can see your blood can trickle down, okay? And remember here that with marginal separation, even though the separation may not be complete as of yet, but blood can still find a way to trickle out. So visible bleeding tends to be more. And remember here that as it marginally separates and comes out, it is the maternal side, the rough side or the dirty side of the placenta that comes out first. Okay. So moving on, what are the signs of placental separation which we check clinically? Okay. So clinical signs of placental separation, first of all, you see here as the placenta separates, you see the uterus is contracting. As the placenta separates, there's all this bleeding also, right? There's all this bleeding also, right? So the uterus becomes, globular. It feels firm because it is contracting. And initially it also becomes ballotable on per-abdominal examination, okay? So blood inside the uterus and then a ball-like mass, that is the placenta here. So the ballotability is there. But this is, yes, the first sign. This is, yes, the first sign. But it becomes clinically very difficult to actually appreciate, especially when the woman is obese, and it's a very subtle sign which can be missed. It's a very subtle sign which can be mixed. And then there could be a gush of blood. Now remember here that when the placenta is separating by central method, okay, the gush of blood may not be evident till very late. Okay, and like I told you, with marginal methods of separation, the gush of blood can occur, or the trickling of blood can occur even with partial placental separation, right? So gush of blood is not very specific. It's not very specific. Okay, now as the placenta separates and comes to lie down in the lower uterine segment, see, this is the upper segment and this is the lower uterine segment. So as the placenta comes down to lie in the lower uterine segment, what happens? There's this contracted upper portion that lies on top, as you can see in this image. So if this was where the umbilicus was, so immediately after delivery, right, the fundus of the uterus is at the level of the umbilicus. And as and when the placenta separates and comes to lie in the lower uterine segment, one may feel a slight suprapubic bulge. One may feel a slight suprapubic bulge. The uterus sitting on top, contracted here. There can be a slight elevation in the fundal height. There can be a slight elevation of the fundal height. Very slight, very slight. Very subtle signs, okay, which can be missed on per-abdominal palpation, okay, especially in case the woman is obese as well. Now, other important thing is that you see here the length of the cord. You see here the length of the cord. Now, this is permanent lengthening of the cord which is visible to you outside. Why? Because the placenta itself is lying in the lower uterine segment. Here also, look at this. The placenta has separated. Okay. But if you give suprapubic pressure abdominally in the upward direction, what can happen? It will go up. Because you're pushing it. Now, you're pushing at the level of the placenta, it will go up, go inside, right? So, this would be apparent lengthening of the cord. However, yes, once there is permanent lengthening of the cord, I mean, you give suprapubic pressure now, what will happen? This will not go up, right? The cord that is already outside now, the length of the cord outside now is not going to go up. So, this is permanent lengthening of the cord, right? So, remember here, this elevation of the fundus on per-abdominal examination, right? This elevation of the fundus on per-abdominal examination is a named sign that is called as the Schroeder's sign. The permanent lengthening of the cord is the most reliable sign of placental separation. And remember here that absence of umbilical cord retraction on suprapubic pressure that I just described to you is called as the Kirshner sign. Okay. So talking about the clinical management of third stage of labor, there are two ways, right? One is the expectant management. Let's talk about that briefly. Now, expectant management means that one waits for the signs of placental separation and allow for spontaneous, expulsion of the placenta or expulsion of the placenta aided by maternal efforts, right? There is no routine use of uterotonic drugs in this situation. Okay, no cord clamping until the pulsation has stopped or even after delivery of the placenta. So just allow the natural childbirth actually without any hands on the patient, without any intervention unless indicated. And with this expectant management, you see the average duration of the third stage is about 15 to 30 minutes. Okay. Now, what we are routinely doing is active management of third stage of labor, AMTSL, right? With this, the average duration of third stage of labor is cut short, right? It is about 5 to 15 minutes, right? Now, remember here that in our country with maternal mortality rates, you see that hemorrhage, especially PPH, is the most common cause of maternal mortality in our country. Our women are also anemic to begin with. So we are going to follow this routinely because it decreases the incidence of PPH. It decreases the need for blood transfusion, and it also decreases the need for any extra additional uterotonics. So that's why for us it is routinely followed. That is what also the WHO recommends, routine active management of third stage of labor. Now, these are the outcomes that are different, but when you compare the expectant management with active management of third stage of labor, there is no difference between the two as far as the risk of retained placenta is concerned overall, right? As far as the risk of or possibility of manual removal of placenta is concerned, or as far as the need for antibiotics is concerned. For excessive bleeding, we may have done, because of retained products or retained tissue beds, and then we may have done, some intervention because of which we want to, some invasive intervention because of which we want to go for antibiotics use. So there is no significant difference between the two methods as far as these points are concerned. So that's also an important point to note. Now, when we talk about the components of AMTSL, right? Uterotonics to be given immediately after delivery of the baby. After delivery of the baby, preferably within 1 minute. If I say immediately, meaning within 1 minute. Now, the important thing to note here is it is after the delivery of the baby, not after delivery of the anterior shoulder, before the anterior shoulder, things like that, because it's very difficult to time exactly after delivery of the anterior shoulder, right? First of all that. Secondly, in case you give it before the delivery of the anterior shoulder, okay, there's the head comes out and shoulder is yet to deliver, and you give this uterotonic before the delivery of the shoulder, then there is a risk or a possibility that if in any likelihood, let's say shoulder dystocia were to occur, okay, and now you've already given a uterotonic. So now there's this intense uterine contractions, and with that, you see, in the face of shoulder dystocia, if it were to happen, it would further impact the shoulder behind the pubic symphysis, right? So remember here that uterotonics immediately after delivery of the baby, as simple as that, right? Delayed cord clamping. Now, what does delayed cord clamping means? Now, various studies have been done where cord clamping has been delayed for 1 minute, 2 minutes, 3 minutes, right? Or delayed till the cord pulsation cease, right? Now, what the WHO is saying that cord should be clamped not before 1 minute after birth. That's an important point. So, technically, if you see, delayed cord clamping is not an intervention that is going to decrease the risk of PPH. However, it is noted with components of active management. Why? Because the WHO says that, there's no early cord clamping. Cord should be clamped in good time. There is no rush, okay? One need not rush to do an early cord clamping, because what happened was earlier, way earlier, early cord clamping was a component of active management of third stage of labor. thinking that if we cord clamp early, it decreases the maternal bleeding, it also shortens the duration of the third stage of labor, all that, right? But now we know that delayed cord clamping is beneficial to the newborn, right? And there is no significant difference if you see whether you cord the clamp early or whether you clamp the cord late. There is no significant difference in the amount of blood being lost in the third stage of labor or blood loss at delivery. So by that logic, yes, delayed cord clamping becomes a component of AMTSL. But remember, technically, it does not by itself, does anything to prevent PPH per se. Then the third component is controlled cord traction, which is recommended to be done and performed only in the setting of skilled birth attendant. Now, we all are skilled birth attendants, so we'll talk about this a little bit more in detail as well. And the other component is intermittent uterine tone assessment. Now, the use of uterotonics is the most important component. With this, the risk of PPH decreases by about 50% at least. The risk of blood transfusion decreases by about 50% at least. So, uterotonics, we're going to talk about that in detail. Controlled cord traction actually is the least important of the components. I'll tell you why. Remember here that with oxytocin use, if you've already given the uterotonic with oxytocin use, controlled cord traction may add a small benefit in reducing the blood loss at delivery or reducing PPH, but it primarily works, or it's primarily a component because it shortens the third stage of labor on an average by 6 minutes, right? So this is the least important component. And understand here that sustained uterine massage before the placental delivery has taken place, sustained uterine massage in the third stage is not recommended as an intervention to prevent PPH in women who've already received a prophylactic oxytocin. So once you've given the oxytocin, there's no need to keep, massaging the fundus. Okay, that sustained massage in the third stage is not recommended. See, there is lack of evidence. There's lack of evidence regarding the role of massage when no uterotonics drugs are given, or let's say drugs other than oxytocin are used. So actually, intermittent uterine tone assessment is good enough to see if the uterus is contracting or not. Now, moving on, let's talk about the use of uterotonics for prevention of PPH. Okay. Now, this is a very, very important aspect which we should know in detail about. So, for all the births, it is recommended uterotonics to be used, whether it is delivery by vaginal or delivery by cesarean. So, the active management protocol doesn't change by the mode of the delivery. Oxytocin 10 units IM or IV is the uterotonic of choice as per WHO. As per the Government of India recommendations, what is the drug of choice? Again, oxytocin 10 units, but intramuscular route. So, I will talk about the routes of oxytocin administration also in a while. But remember here that oxytocin acts physiologically on the uterus, right? It contracts the upper segment, does not contract the lower segment that much. So, allows for physiological action. All right, so that the upper segment is contracting to push the placenta out and the lower segment can receive the placenta, right? Also, it has, very fewest side effects actually among all the uterotonics, and there are no absolute contraindications. So, it is a drug which can be easily used in the peripheral healthcare settings, right? Also, remember that the Government of India recommendations, they apply to village health workers also, midwives also, right? So, the recommendation from them is give 10 units IM. Right? IV bolus, that we all tend to avoid because it can lead to dangerous side effects like hypotension or like, dangerous tachycardia. If oxytocin is unavailable, what are the other recommended drugs like ergometrine or methyl ergometrine, right? Fixed drug combination of oxytocin and ergometrine. Now, these injectable, agents, these injectable uterotonics, they can only be given if the contraindications can be ruled out. Okay, so as specialists, it's easier for us to rule out the contraindications, but that may not always be possible in the peripheral healthcare settings, and that is why oxytocin becomes the uterotonic of choice naturally. Now, if you talk about oral misoprostol, that is also a drug that can be used in case oxytocin is unavailable. We're going to talk about that also. And please remember that carboprost and sulprostone, these are also injectable uterotonics, right? Carboprost is PGF2 alpha and sulprostone is the injectable form of PGE2. They are not recommended, right? Because when you compare the side effects, when you compare the cost versus, are they having any benefits in comparison? Are they having any extra benefits in comparison to oxytocin? Then really the conclusion is that because of high cost, because of side effects, and they really do not offer any significant benefit over oxytocin, they are not recommended by WHO for prevention of PPH. Okay, they are used, yes, PGF2 alpha is used in treatment of PPH, but not in prevention of PPH. Remember that. Now let's talk about the routes of oxytocin administration, because the WHO in its recommendation is also saying that IV oxytocin can be used. Now, under what circumstances? Let's also talk about that. Okay, but before that, with IV oxytocin, you see there is almost immediate action, and the peak concentration in the circulation of oxytocin reaches after about 30 minutes. With IM oxytocin, the onset of action is in about 3 to 7 minutes, and the clinical effect lasts up to 1 hour as well. With IV also, the clinical effect lasts for approximately about 1 hour. So with IM, the onset is delayed slightly, and with IV, the onset of action is almost immediate. That's a significant difference. Okay. Now, we already know that with IV bolus, there is risk of hypotension and tachycardia, which is particularly more relevant, in case the woman is already, let's say, having hypovolemia, maybe because of bleeding, hemorrhage, right? Or she has tachycardia already, maybe also because of, hypovolemia, or maybe because of, some heart disease conditions, where for her tachycardia is going to turn out to be dangerous. So we have to take concern of those important points also. But all in all, yes, we know that IV bolus is something that we never give. So what is this recommendation about IV oxytocin? Let's dig into that. The WHO is saying that in situations with IV access already in place, 10 units slow IV is preferable over IM. Because they've said that with slow IV, there have been studies showing that, the risk of PPH or the need for blood transfusion, need for additional uterotonics, that is decreased as compared to IM. So IV, they are saying, is preferable in that aspect. But this evidence in favor of, IV oxytocin is mainly from low quality studies. But even then, yes, see, when the WHO has made its recommendation, they have also concluded that there is no direct comparison between different IV regimens. Okay, whether it is IV infusion, what dose of IV infusion, what is the rate of IV infusion, whether it is 5 units IV or 10 units IV, right? Whether it is 5 unit IV and 5 unit IM. So that kind of direct comparison between different IV regimens is also not there. Different studies have used different regimens, right? However, they do go on to say that no safety concerns have been documented in the trials. Trials which compared 10 unit slow IV over 1 minute versus 10 units IM, provided that, okay, there's no risk of hypotension, pre-existent hypovolemia is not there, provided pre-existent tachycardia is not there, So no safety concerns in trials comparing 10 units slow IV over 1 minute versus 10 units IM. So that is one thing that they have said. So they do mention to avoid rapid IV, dilute and give if you're giving IV, and administer very, very slowly. That's all that is they are saying. Okay, but when you read up the NICE recommendations regarding active management of third stage of labor, the NICE guidelines on intrapartum care, they are saying that one can give 10 units intramuscular oxytocin or 5 units IV slowly over 3 to 5 minutes if they have received oxytocin in labor. Okay, so they were already getting oxytocin, they were already on an infusion, IV line is already in place. So they are saying that give 5 units IV slowly over 3 to 5 minutes if they have received oxytocin, and this seems like a reasonable approach, right? Now, the other drug, let's talk about methyl ergometrine, which is used in a dose of 0.2 milligram IM as well as IV for active management of third stage of labor. If at all one has to give, I would prefer IM over IV because of the side effects which are more with IV dose, like the sudden hypertension is a very, very important side effect which primarily happens with IV regimens. Okay. Now, with IM, the onset of action occurs within 2 to 3 minutes, lasts for about 3 hours. So, we get a longer duration of action. With IV, the onset of action is within a minute and lasting for about 45 minutes, right? So, in cases when we have to give methergin for PPH, okay, methergin for PPH, not for prevention of PPH, treatment of PPH, we tend to prefer IV. Okay, so remember these important points here as well. Now, there is no clear evidence of any difference between methergin and oxytocin for PPH prevention, meaning that they both are equally effective as far as efficacy is concerned. So, there is no difference in their efficacy for PPH prevention, but there are going to be more side effects with methergin. You will also have to rule out contraindications of methergin as well. So remember here, the side effects could be nausea, vomiting, hypertension, headache, abdominal pain. Now this abdominal pain also happens because the methergin makes the uterus contract tonically, induces tonic contractions of the uterus, the upper segment also, the lower segment also, and it has been seen that the chances of retained placenta are slightly more with the use of methergin as compared to oxytocin. So that's another important concern when you compare oxytocin with methergin, all right? Can use only if there are no contraindications. So you have to remember the contraindications: hypertension, preeclampsia and eclampsia. So you know that methyl ergometrine, these are vasoconstrictors. Okay, they cause peripheral vasoconstriction, and that's why they cause hypertension as a side effect. If they can cause sudden hypertension, right, that is going to put load on the heart, isn't it? And that is why it is contraindicated in patients with heart disease also. Okay, because it can precipitate sudden heart failure in those patients as well, right? And also when it tonically contracts the uterus, right, there's this all extra blood in the uteroplacental circulation, and that, you know, seeps into the maternal circulation, further increasing the venous return, and that is also going to be a problem with patients of cardiac disease who cannot tolerate these fluctuations of blood pressure. Then it is contraindicated in patients with peripheral vascular diseases, HIV positive patients on protease inhibitors. Okay, because both together, protease inhibitors and methergin, they cause hypertension as a side effect. So it can compound the hypertension. That is what it is. And another contraindication is Rh negative women. Now I've marked an asterisk over here. Why? Because as long as the placenta is inside in the third stage, when we use methergin, again because of the tonic contractions, there is this risk of, you know, increasing feto-maternal hemorrhage. But mind you, in the face of PPH, when PPH is happening and the placenta is already out, then one can use methergin even in an Rh negative woman if the need is, because now the concern is, you know, treating the PPH that is already taking place and the placenta is already out. So remember this important bit also. Now let's talk about the recommendations on the use of misoprostol, that is PGE1. Now in the settings, let's say where oxytocin or the other injectable uterotonics are either unavailable or they cannot be used. For instance, there is skilled health personnel, they are not present to administer injectable uterotonics. So that is mainly relevant in peripheral healthcare centers where, let's say, the midwives or the nursing staff that is not skilled, let's say, to give injectable uterotonics. They are the ones, lay healthcare workers, they are conducting the delivery. Then misoprostol in a dose of 400 to 600 microgram per orally by community and lay healthcare workers is recommended for prevention of PPH. That is what WHO says. You see, if you compare how effective is misoprostol, okay, you compare it with oxytocin, then less effective for preventing severe PPH in comparison to oxytocin. So if you have oxytocin, you definitely know that oxytocin is your drug of choice, right? There's no special storage requirements. That is the advantage. Okay, even though it may not be as effective, but the advantage that it gives is in these settings, right? Because it is not requiring any special storage requirements. It is stored at room temperature. It is found on the shelf lying there, right, with all your other medications, all that, but it needs to be protected for humidity, that's all. With oxytocin, with methergin, these are drugs that need to be stored in the refrigerator to increase their shelf life at 2 to 8 degrees Celsius. For oxytocin, it is very, very important to maintain the cold chain. So there could be a peripheral healthcare center where the refrigerator is not there, where the refrigerator is there, electricity is not there, or the refrigerator is not working, or whatever be the reason for the failure of the cold chain. Okay. So in those circumstances, if you have misoprostol, one can use it, right? It's cheaper, it is cost effective as compared to the other injectables like methergin or symptometrin. Symptometrin is the fixed dose combination of methergin and oxytocin. Now the side effects, however, is a limiting factor, but most of the times these are manageable. The side effects like shivering, fever and diarrhea, but the important thing is that community healthcare workers, lay healthcare workers can use it because there's no absolute specific contraindications to misoprostol as compared to methergin. Remember that also, right? And these side effects depend upon the dose of misoprostol, right? They also depend upon the route of misoprostol administration. Like for instance, lower dose, like 400 dose, will have lesser side effects as compared to 600 dose. But which dose will be more effective? Is the 600 dose more effective, or is the 400 dose equally effective? So there are no clear-cut evidence regarding this, that 600 microgram dose is more efficacious or not. And there are no clear-cut studies saying that the 400 microgram dose is equally efficacious. However, what we do know is lower dose will have lesser side effects. And you know that oral and sublingual routes, they allow for more rapid onset of action, but more gastrointestinal side effects. With vaginal and rectal routes, there is a slower absorption, a constant rate of absorption. So they have prolonged action and greater bioavailability. That's the advantage of the vaginal rectal route. So why the PO, per oral route, was recommended by WHO? The WHO in its recommendations goes on to say that the 600 microgram per oral dose is recommended. Why? Because in the studies, women most preferred the oral dose. Having said that, one can give by the vaginal or rectal route also, with that logic. Okay. Now, let's talk about another drug that is being talked about a lot these days, and that is carbetocin. Now, it is a synthetic analog of oxytocin, and the natural oxytocin is a nanopeptide, whereas carbetocin contains 8 amino acids. It's an octapeptide, and it is long-acting. That is the most important point to note about this. Carbetocin has a half-life of about 40 minutes. As compared to oxytocin, which has a half-life of about 1 to 6 minutes. Okay. And nowadays, yes, the heat stable formulation of carbetocin is also available. So if you compare the routes of carbetocin, IV versus IM of carbetocin, okay. So with IV route of carbetocin, you get sustained contractions within 2 minutes and lasting for about a duration of 6 minutes, and rhythmic contractions, they persist for about 60 minutes. With IM carbetocin, one gets sustained contractions lasting for about 11 minutes, and rhythmic contractions can last for about 120 minutes as well. So it is a long-acting analog, right? Now, what are the advantages and what are the recommendations? Now, the WHO says that 100 micrograms of this carbetocin, IV or IM, is recommended for prevention of PPH for all births. All births meaning whether by vaginal, whether by cesarean section, in context where it is cost is comparable to other effective uterotonics, meaning that as long as it can be made cost effective, it can be used, is recommended for prevention of PPH for all births, right? So earlier, much of the studies concerning the use of carbetocin were done in patients who had a cesarean section. And much of the evidence was from the utility of carbetocin in preventing PPH in cesarean section patients. So the NICE guidelines still NICE guidelines from Interpartum Care 2023, they recommend carbetocin as slow IV injection, right? So carbetocin is a vial which is containing 1 ml of solution, 1 ml of solution containing 100 microgram of carbetocin that can be given as a slow IV injection over, let's say, a couple of minutes, or it can be diluted and infused. So that is recommended for prevention of PPH in women undergoing cesarean delivery. That is what the NICE recommendations are saying, right? And you will be questioning, then why does the WHO come up with this recommendation that it is recommended for all births? Understand here that the evidence regarding that is from this very huge study, the Champion Trial Group. Okay, and this was published in the New England Journal of Medicine. Heat stable carbetocin versus oxytocin to prevent hemorrhage after vaginal birth. So they conducted this study, which was the carbetocin hemorrhage prevention trial. Carbetocin hemorrhage prevention trial, the Champion trial. It is a multi-center international randomized control study. It was a double-blinded trial also. So it's a very good trial which was conducted primarily to answer this question, whether or not carbetocin is as effective, more effective, or less effective as compared to oxytocin to prevent PPH. So what they have concluded is carbetocin is not inferior. So it was sort of a non-inferiority trial. This is a good trial to read up actually, right? So it's a non-inferiority trial, meaning that they found that carbetocin is not inferior to oxytocin. Now you could interpret it as, is it equally good? One cannot really say. It's definitely not more efficacious, but it's not inferior to oxytocin in decreasing PPH, primary PPH, blood loss at least 500 ml. When PPH is defined as blood loss at least 500 ml and need for additional uterotonics. That's why the WHO came up with these recommendations that carbetocin can be used in vaginal deliveries also for prevention of PPH, but only limitation as of now with carbetocin in comparison to oxytocin is its cost. So in our government hospitals, oxytocin, we have concluded in the end that oxytocin is our drug of choice so far, right? Easier to administer, fewest of the side effects, right? No such absolute contraindications are there, isn't it? It has been used for a long duration of time as well, right? But yes, with carbetocin, what we tend to gain, when if at all we use carbetocin, what we tend to gain is the longer half-life, right? And the longer duration of action as compared to oxytocin. So it has been seen, the people who are using carbetocin, they vouch for it, that they really have to give no additional uterotonics once they have given carbetocin in the third stage of labor for prevention of PPH, right? Sometimes in post cesarean cases, you will see that in the IV fluid vac also we are giving oxytocin, especially when you have a system or health care circumstances where one-on-one monitoring of patient may not always be possible. So with IV fluid, we give the oxytocin infusion also in post cesarean section patients so that they don't have PPH later on. Now that can potentially be avoided if we use carbetocin, isn't it? So that's the logic of using carbetocin. Nonetheless, please remember that carbetocin is not recommended for treatment of PPH. There have been no studies in this regard. It is not recommended for induction of labor. It is not recommended for augmentation of labor where oxytocin is used. In this champion trial that was conducted, carbetocin was not used in patients with complications also. So as of now, do not use it if there is cardiovascular diseases, if there is liver or renal disease. Don't use it in complicated patients. Or let's say in patients with epilepsy also, it was not used. These were exclusion criteria of this particular study. So keep that in mind as well. And lastly, before I finish off the uterotonics, centometrine. Just a short note on centometrine. Now, centometrine is a fixed dose combination of centooxytocin, 5 units of oxytocin, plus methyl ergometrine, 0.5 milligrams of methergin. Right. Now, as far as centometrine is concerned for prevention of PPH, studies show that it may be marginally more effective as compared to oxytocin alone. As compared to oxytocin alone, it may be marginally more effective, but then it will have the side effect profile like that of methergin. It will have the same contraindication profile like that of methergin. And in our labor rooms, we generally don't use centometrine. Okay, it's also costly. Now let's talk about delayed cord clamping versus early cord clamping, and what's the biggest advantage of delayed cord clamping. We all know that it allows for placental transfusion to the newborn. Okay, that means it allows for extra blood to reach the fetus, and that is what happens physiologically also. That is what nature also wants. That is how things are designed. Think about it. Just recall, when the baby delivers, right, then there's this initial few cries, and what happens is that there is lung inflation with the initial few breaths. Okay, there's this negative intrathoracic pressure. That also helps in this placental transfusion to the newborn. We also know physiologically, fetal circulation has to, now become the adult circulation, isn't it? So what happens? Remember this, the negative intrathoracic pressure. Recall from your physiology. Closure of ductus arteriosus. Remember that umbilical artery contracts first. Okay, umbilical artery takes blood from fetus towards the placenta. That's contract first. See? Now, what will happen? The fetus will not bleed into the placenta because it contracts first. An umbilical vein contracts later. Umbilical vein takes oxygenated blood from placenta to the baby. So all of this is going to be something which is physiological, and delayed cord clamping allows for it. Had we done early cord clamping, we would not be able to get this advantage, right? So extra blood reaches the fetus, leading to higher newborn iron stores. So it has been said how much of this extra blood reaches the newborn. If you look at it, then if we delay the cord clamping for about a minute alone, okay, then 80 ml of extra blood reaches the fetus. And if we happen to delay till about 3 minutes, then 100 ml of extra blood reaches the fetus approximately, and this together would approximately amount to 40 to 50 milligram per kg weight of the newborn. Very significant in building up the iron stores of the newborn in a country where the childhood anemia rates, where the infant anemia rates are also significant, right? So it will lower the rates of newborn anemia in the neonatal period and in the infant period as well. Now, as far as the preterm newborns are concerned, right, this placental transfusion will also happen in preterm newborns, and that is going to give them the same advantage, right? Decreased rates of blood transfusion have been seen. Placental transfusion will avoid hypovolemia and therefore also decrease rates of intraventricular hemorrhage and necrotizing enterocolitis in preterm newborns. It also tends to, you see, avoid sudden fluctuations in BP. Sudden fluctuations in the blood pressure, which these preterm newborns particularly may not be able to tolerate. See, when we follow delayed cord clamping, we go as close to possible as what nature meant. Smooth transition from the fetal circulation to the adult circulation, or to the fetal circulation to the newborn circulation, avoiding the fluctuations in blood pressure that can happen with early cord clamping. Okay. There was concern that, with delayed cord clamping, maybe the resuscitative efforts, directed towards the newborn, they may not be possible. But overall, there is no difference in the newborn APGAR scores, right? There is no difference in maternal PPH rates and post-delivery hemoglobin status as well, right? Because there was concern that if delayed cord clamping is done, maybe the woman will lose more blood. But that is not true, okay? So there's no difference in maternal PPH rates and post-delivery hemoglobin status also. Now, there is only one potential harm regarding delayed cord clamping, and that is increased risk of having hyperbilirubinemia in the newborn, potentially because, extra RBCs reaching the newborn circulation and therefore increased risk of hyperbilirubinemia. But the risk of neonatal phototherapy rates, they do not differ in the two groups between delayed cord clamping versus early cord clamping. So this is only one point with delayed cord clamping. And in setups, in institutional setups where pediatricians are available, where one can look into the development of hyperbilirubinemia, or that monitoring can be done, I think this potential harm can be disregarded as compared all the other benefits of delayed cord clamping that are achieved. So the benefits outweigh the risks. Okay. Now, let's also talk about the conditions in which early cord clamping, however, should be considered. Like, for instance, there is maternal hemorrhage in the 3rd stage of labor. Now, you know that the maternal bleeding is not going to stop till the time the placenta is delivered and the uterus contracts, isn't it? So, maternal hemorrhage and or hemodynamic instability. I mean, you could be delivering a woman with placenta previa or maybe with placental abruption, right? Then in those situations, yes, of course, early cord clamping is recommended, right? Or let's say there is an asphyxiated newborn in the need for resuscitation. The baby is delivered, the baby is not crying, the baby is limp, right? Needs immediate resuscitation in the form of, assisted ventilation. For that, you have to give the baby to the pediatrician, right? So asphyxiated newborn in need of resuscitation, the NICE guidelines recommend. Now, there's this one important point given by NICE guidelines, that if the newborn heart rate, okay, if the newborn heart rate is less than 60 beats per minute and is not picking up, early cord clamping just after the delivery of the baby, right? And let's say if there is any concern that the placental circulation may not be intact, for example, situations with placental abruption, or there is fetal growth restriction with abnormal Doppler in which there is already placental dysfunction, or if the integrity of the cord is in question, let's say avulsion of cord occurred, then one would also need to go for delayed cord clamping. So this is very situational, right? And lastly, if there is known, congenital heart disease in the newborn. Now, this you will have to consult with the pediatrician also, because there will be certain heart diseases, congenital heart diseases, which cannot tolerate blood pressure fluctuations in the newborn life, or which cannot tolerate extra amount of blood reaching the circulation, because that would put a load on the heart. So this has to be worked out in consultation with the pediatrician. So that is another situation where you would possibly consider early cord clamping. So all this is very situational, right, during the course of third stage of labor. Now, let's talk about another controversial area, another area of debate, which is cord clamping in HIV positive women, whether delayed, whether early, right? Now, those who are saying that early cord clamping should be done, they basically raise a concern that there is a possibility of microtransfusion of maternal blood into the baby, into the fetal circulation, into the newborn circulation with a partially detached placenta. That is the concern that they raise. So that's why they say early cord clamping should be done to avoid this, right? Now the counter is here. First of all, let's talk about the theoretical concern before we talk about the counter. So the theoretical concern is that there is a possibility of disruption of fetoplacental circulation, and newborn circulation may get exposed to maternal circulation, but that would be possible if there is disruption of fetoplacental circulation, because in the placenta the circulations are separate. Maternal blood is in the intervillous spaces, fetal blood is in the chorionic vessels. If that integrity is broken, then yes, of course, this can be true. Okay. Now, the WHO says that the main intervention, how we prevent mother-to-child transmission of HIV, is by giving antiretroviral therapy during pregnancy, during childbirth, and even for the newborn in the postnatal period. That is our main mechanism of how we are, decreasing maternal to child transmission. So the benefits of 1 to 3 minute delay in cord clamping, the benefits that are gained, they actually outweigh the theoretical and unproven harms of delayed cord clamping in HIV positive women. So much of the evidence goes again in favor of delayed cord clamping in HIV positive women as per the WHO recommendations. Okay. Now let's talk about milking of the umbilical cord. Now, milking is, let's say, squeezing of the umbilical cord to facilitate, that placental transfusion towards the newborn. So this process, milking, that could only be considered, let's say, for term newborns in case rapid cord clamping is clinically indicated. You have to do rapid cord clamping. Within a minute, you have to within a minute, you have to clamp the cord. You're in a rush. And you want to give the newborn advantage of extra placental transfusion also, extra blood also. So one can milk the cord before clamping. So that is probably the only area where milking could be done. But it may be harmful for preterm newborns. Some studies show that it can also be associated with increased risk of intraventricular hemorrhage, and there is conflicting data in that sense, right? Now, please remember that milking of the umbilical cord is not recommended for extreme preterm newborns, which are less than 28 weeks, and there is insufficient evidence to either support or even to deny or neglect or refute the practice at later gestations, even at term. Okay, so what we want to do is delayed cord clamping. Milking is something which could be harmful, especially in preterm newborns, right? So the only place where one could even consider is term newborns if early cord clamping or rapid cord clamping is clinically indicated. That would probably be the only situation where one could do, milking of the umbilical cord. And other than that, WHO actually recommends against it. Okay, so WHO, remember, recommends against it. Okay, so with this we finish off the most important and crucial aspects about uterotonics and about the cord clamping procedures. Now let's talk about the clinical management of third stage of labor. Let's summarize it. Okay, so start thinking ahead, get ready when you are delivering the baby's head. This is the time that when you are ready and you are telling the staff or your sister to load the oxytocin vial, so that as soon as the baby is delivered, as soon as both the shoulders are delivered and the baby is in your hands, the staff will give the oxytocin injection, which is going to be 10 units IM as far as the Government of India recommendations are concerned, and mostly we are doing that in our labor rooms. Okay, now also remember here that sometimes there may be a loop of cord, nuchal cord. Okay, so when there's a loop of cord around the neck, whether there's 1 loop, 2 loop, 3 loop, whatever, don't get hassled. Mostly those loops are loose enough, you can roll them out. Okay, you can take them out of the baby's neck, because the concern is that as you're going to pull the baby out, the cord will get, the loops of the cord will get tightened, first of all that, and as they get tightened, they are going to interfere, they are going to get compressed. The umbilical vessels and sides are going to get compressed, and they're also going to interfere with the baby breathing and baby crying, right? So slip off those loops of cords around the neck. Even with a tight loop, even with multiple loops, it's always possible to do so. Or sometimes because the baby is delivering so fastly, you'll realize that you've delivered almost and then you may be uncoiling, right? So you can also deliver like that. Only and only in situations where it is too tight, it is interfering with the delivery of the baby, it is interfering with, you uncoiling the loops, maybe then you can think about clamping and cutting it in between the two. Try to avoid it as much as possible. Why? Because when you clamp it like this, you have interfered with the circulation. Okay, you've interfered with the link between the maternal and the fetal circulation right there when you clamp and cut it. Okay, and just in case any problem in delivery were to happen after that, just in case if shoulder dystocia were to happen, then your delivery gets lengthened and prolonged and you've broken the oxygenation of the fetus. That's an important point to note. So try to avoid clamping and cutting the nuchal cord right here. Okay, try to uncoil it. That is the best thing to do. Most circumstances you will be able to do it. Now, the other thing that you're going to do is once the baby is delivered and the oxytocin injection has been given by the sister, oxytocin injection given, what are you going to do? Examine the fundus immediately after delivery. Why do you want to examine? You're going to note the position of the fundus immediately after delivery of the baby. It is going to be just at the level of the umbilicus or slightly maybe below it. Okay, because you want to note the signs of placental separation. You want to note the uterine contraction. You've already given the uterotonic, now intermittent uterine tone assessment. Now you're going to note for uterine contractions also. Is it atonic or not? And very, very important, exclude a second baby. Now, why do I say it's important? Because we work sometimes in situations where our patients could be unbooked, maybe having no records of antenatal checkups, maybe having no ultrasound reports, right? Yes, your antenatal clinical examination is going to help you. Obviously, you would know if it is a singleton pregnancy or if it is a multiple pregnancy, if you have conducted the clinical examination. But even then, sometimes surprises could happen in obstetrics. Obstetrics is a very surprising branch sometimes. So exclude a second baby. Okay, because if there is a second baby yet to deliver, then uterotonics cannot be given. Should not be given, isn't it? So that's an important point to note. After this, you follow with delayed cord clamping. Wait it out, avoid rushing into cord clamping until unless there is an indication for early cord clamping. The other important point is, where do you keep the baby? Delivery, or put it on the maternal chest or maternal abdomen, right? So that is an important point, position of the baby and the effect of gravity as far as the process of delayed cord clamping is concerned, right? Now, the thing here is that if this is the placenta, let's say, and this is the level of the baby, okay? Now, umbilical vein brings oxygenated blood to the baby. Umbilical artery takes blood from the fetal side, from the newborn side to the placenta. This is placenta post-delivery, okay? So, let's say if the baby were kept at a higher level. Let's say if the baby were kept at a higher level, then what would happen? Umbilical artery and umbilical vein, okay? So, if the baby is at a higher level, the placental transfusion, the amount of placental transfusion would be decreased. The amount of placental transfusion would be decreased, isn't it? Because of the effect of gravity. So, the effect of gravity could be there, isn't it? And then, if you have baby put at a lower level, okay, then this would increase the speed of placental transfusion to the baby. Okay, that is well documented, okay, but we are using oxytocin. Already we've given uterotonic. Without the use of oxytocin, the effect of gravity on placental transfusion is most pronounced, most evident, at least when there is a distance of plus minus 20 centimeters above or below the placenta. 20 centimeters above or 20 centimeters below the placenta. That's why I've written plus minus, actually above and below the level of the placenta or the level of the introitus. Placenta we can't really figure out, but we'll figure out the level of the introitus basically. So there is an effect of the position of the baby and the effect of gravity on the amount of placental transfusion. Okay, so with the effect of gravity, we see that there is increase in speed of placental transfusion to the baby, but the net amount of placental transfusion does not necessarily change much, especially when we have already given oxytocin as a part of active management of third stage of labor. So with the term vaginal delivery, women who have been already given oxytocin within a minute of birth, so there is an effect of oxytocin also, oxytocin inducing stronger uterine contractions, placing the baby on the mother's abdomen or chest did not affect the volume of placental transfusion or the total volume of placental transfusion or the advantage of extra blood to the baby, right? Also remember that as and when you are, following the process of delayed cord clamping, your early essential care of the newborn is initiated, right? Secretions are cleared, or if they are copious or they appear to be obstructing the airway. Otherwise, a good vigorous newborn who's crying is good enough, isn't it? Meconium if present and the baby is vigorous at birth, then also delayed cord clamping can continue. So these are important points to note. Next aspect of conducting the clinical management of third stage of labor is actually performing controlled cord traction to deliver the placenta, right? So it is to be done with uterine contractions. That is the most important point. Second important point is that always and always pull at the cord or apply traction along with counter traction. The name says controlled cord traction, but it has to always be controlled by applying a counter traction. That's very, very important. This is a skill that all of us should be learning in our labor rooms. So you can see here that the backwards and forwards pull towards yourself and backwards is applied on the umbilical cord, and another hand is placed here right above the pubic symphysis, somewhere roughly at the junction of the lower segment and the upper segment. And with this simultaneously, traction and counter traction together along with uterine contractions, right? So we have to place a hand on the abdomen here. This actually helps us to also feel for uterine contractions so that we are not tugging at the umbilical cord when the uterus is relaxed. If the uterus is relaxed and we are tugging at the umbilical cord, what can happen? Uterine inversion can take place. Okay, let's say the placenta is here, it is still attached, and we are inverting the uterus. Uterine inversion can take place, and we are tugging at the cord. Okay, and we feel, oh, it is coming down, oh, it is coming down, because what I'm feeling is an apparent lengthening of the cord when actually the placenta has not separated. I'm feeling an apparent lengthening of the cord, placenta has not separated, so I can be fooled. Don't get fooled. Place your hand here, be cautious. Okay, tug only when uterus is contracting, apply traction only when the uterus is contracting. So that is the most important aspect. Okay, now the other question which is often debatable is when to begin controlled contraction. I mean, should we do it after the signs of placental separation or before the signs of placental separation? Okay, now understand here that what NICE guidelines, latest NICE guidelines on intrapartum care, they recommend to start with controlled cord traction after signs of placental separation. Right. Now, I would say that this is safer practice. Right, that's because anyways we are going to give uterotonic. Okay, let's say we have given 10 units IM oxytocin after delivery of the baby, then we have initiated our third stage labor care, we have allowing time for delayed cord clamping. So the logic is that by the time you are ready to actually deliver the placenta, uterotonic must have taken effect, contractions must have started, and now I'm expecting the placenta to separate. It is always safer to have signs of placental separation before we do controlled cord traction. It is always safer that ways. But also understand here that sometimes the signs of placental separation may not be that obvious. Okay, and then in that situation, what is more important to keep in mind is that you initiate the controlled cord traction with uterine contractions. Okay, so what we tend to do clinically is we give the uterotonic, right? Okay, then we allow for delayed cord clamping. We are not in a rush. There is no third stage bleeding. There is no other indication for early unnecessary intervention. We are going for intermittent uterine tone assessment. And once the contractions begin, we start with controlled cord traction like in this manner. Because sometimes what can happen is that we may have an apparent lengthening of the cord because of this blood, retroplacental hematoma, the central method, the more common method. We can have blood collected here and we can have this apparent lengthening of the cord. And if we were to just do a PV, we may find, okay, the placenta is right here at the internal os. So again, this is a point where you know that you can start with, controlled cord traction. Okay, so I've told you what is done in clinical circumstances. Okay, the important point to note is that it should be done with contractions. You can take the opportunity of starting controlled contraction as soon as there is, contractions that they have, rhythmic contractions have set in. So keep that in mind. And also remember that NICE does recommend that it should be done after signs of placental separation. That is what NICE recommendations say. And yes, of course, if there's no urgent intervention, this would be a much safer option, provided that your signs of placental separation are clinically very, very obvious and you have determined so. Now, important point to note is that this is a method which will require training. Therefore, it was not to be done if skilled birth attendants are not available as per the WHO. This countertraction also helps us detect and also helps us prevent uterine inversion, because with this countertraction, we are pushing the fundus up, isn't it? With this countertraction, we are pushing actually the fundus upwards and backwards. Very, very essential, very, very important. Examiners often ask you to demonstrate this also. Now, after the delivery of the placenta, there is no use of routine exploration of the uterus. That is something that is not recommended. Even in previous cesarean cases, do not routinely explore the uterine scar. There's no need to unnecessarily intervene. Okay, keep that in mind. Very, very important pointer. And also remember here that what is more important is to examine the placenta and the membranes, whether it has been completely expelled or not. If there is a suspicion, clinical suspicion, that maybe some lobes of the placenta are missing, right? Maybe the membranes are still inside, because you have to examine it in totality. So if you have suspicion, then one can explore the uterus, because retained placental bits, retained bits of membrane, they will affect the uterine contractility also. So you have to look into that. So many times that would be a clinical clue. You'll realize that you have separated the placenta, but the uterus isn't contracting that well. It's probably having, that intermittent bits of relaxation in between with contraction. It is not that hard uterus that you, hard and firm uterus that you feel. So then you might suspect that there is some, membrane bits are lying inside or retained inside. Then one can explore the uterus. Also look for the presence of abnormalities, right? Like I said, any lobes missing, or also examine not just the maternal side of the placenta, but the fetal side of the placenta as well, because you could have those leash of chorionic vessels that you can see traversing through the fetal membranes. Maybe there could be a suspicion of succenturiate placenta. So keep that in mind. Documentation is so very important. You will have to document, because if you find that, you may be suspicious that maybe there is some retained placental bit inside also. Maybe there is a succenturiate placenta. So keep that in mind as well. And when you are examining the maternal surface of the placenta, then of course you can count, figure out if there's a lobe missing or not. Other than that, you can also figure out if there is some retroplacental clot. Okay, if it is there, then you need to document it also. Examination of the placenta is also important in the sense that there may be certain situations where the placenta needs to be sent for histopathological examination, right? Now, we've discussed this in a separate lecture altogether where we're talking about placental abnormalities. So I would refer you to go there, read it up, right? So maybe in certain situations, placenta needs to be sent for histopath examination. So only in certain situations, not all the time, okay? Also, at this point in time, once you're done with this much, examine the lower genital tract for lacerations, right? So once you've ensured that the uterus is contracted, bleeding is within normal limits, then you focus on repairing for the lower genital tract lacerations, right? If it is an episiotomy, this is the time to repair it. If there is any tear, you need to repair it, okay? If there is any suspicion of cervical tear, any excessive bleeding, then you have to go for complete cervical exploration also, right? That depends. Close observation of the vitals in this stage, because now we've entered the fourth stage, isn't it? We've entered the fourth stage. So close observation of vitals is important. One needs to check the pulse rate and blood pressure at least every 15 minutes for the first 2 hours here in the fourth stage. So close observation of vitals is important. You do not want to miss out if there is any tachycardia, which could point towards whether there is any excessive amount of bleeding. Continue the assessment for ongoing bleeding as well during this period in time, and continue with the intermittent uterine tone assessment. Something that is very crucial at this point in time, especially in the fourth stage, the 1 hour period of observation after the placental delivery. Why? Because I'll tell you, and consider them in totality, okay? Because it will happen to you so many times that you may have a patient with just a tachycardia, okay? Sister telling you that your patient is having tachycardia in the labor room while being observed, okay? The first thing that comes to your mind is excessive bleeding, okay? Then you think about, you ask the sister whether there is visibly external bleeding or not. She examines, she tells you no, there is not. Right? Now, what is important here to note is that sometimes, especially when the patient is lying supine, lying on a bed supine, right, then what can happen is that the blood is collecting here inside the uterus, okay, and your per abdomen examination should be able to detect if there is uterus atonicity. There may not be a visible bleeding. Excessive bleeding may not be visible, right? But on per abdomen examination, you know that the uterus is relaxed. You can feel that. Or your fundal height may be elevated. So note these points. Your fundal height may be elevated because of this distension of uterus with clots. You massage it now. You massage it now and you see the blood and clots trickling out. Okay, and also important to note here is that sometimes there can be a full bladder. So while you are at the per-abdominal examination, don't miss out on this important aspect. Sometimes there can be a full bladder which actually interferes with the contractility of the uterus, mechanically interferes with the uterus contracting. The moment you will, empty the bladder, you will realize that the uterus starts contracting. So these are important tidbits to note, important clinical vignettes to note during your fourth stage of labor care, which is actually a continuum. It's actually a continued process of care, isn't it? Same principles apply when you have a patient, presenting with PPH. The same principles apply. That's why close observation of vitals, continued assessment of ongoing bleeding, and do not miss out on intermittent uterine tone assessment. Apart from intermittent uterine tone assessment, it is giving you so much extra clinical information also, isn't it? So keep these important aspects in mind. And with this, we finish off the lecture. And lastly, yes, do not forget, newborn care is also a part of the management here. Early institutions of breastfeeding as soon as possible after delivery, and the other aspects of newborn care are going to be implemented after delivery of the placenta. Thank you so much.